Hi, everyone. My name is Dr. Ross Goldberg. I'm a licensed clinical psychiatrist and clinical assistant professor at the Department of Child and Adolescent Psychiatry at NYU Langone Health. And today we're going to be talking about what every parent should know about antidepressants. So if you have questions throughout this talk, feel free to kind of drop them in the comment box. So let's start off by just defining what is an antidepressant. So an antidepressant is a medication that's been shown to decrease the symptoms of depression in scientific studies. Antidepressants in general affect neurotransmission. So we want to think about this, kind of the basic unit of the brain are these neurons or the cells within the brain. And they interact with one another and the way that they communicate with one another is through neurotransmitters or these chemicals. And so antidepressants affect kind of the chemical amounts that are being used between these two neurons between the neurons within the brain to communicate. And there are many different types of antidepressants. There's many different families of antidepressants. The older ones that typically have more burdensome side effect profiles. So for today's talk, we're going to focus on kind of our first line, meaning what's prescribed first and most commonly prescribed for children and adolescents, which would be the selective serotonin reuptake inhibitors or SSRIs. So for those of you who would like a brief science lesson, tune in right now. So this is on the image to your right is a picture of two neurons. So this is the end of the first neuron, which is the cell of the brain, and the second neuron, which is here. And in between this area is the area that the neurons kind of communicate with one another through all these little, if you see these blue images, this is serotonin, which is a chemical released by the first neuron that kind of then lands on the receptor of the second neuron. And the way that the antidepressants work, the SSRIs or selective serotonin reuptake inhibitors work, is they actually block the reuptake of serotonin. So some of the serotonin that's initially released then goes back up into the first neuron. In this case, it's blocking that, which is going to lead to an increase in serotonin within the area between the two neurons. And the ways the SSRIs are used in children and adolescents is we can see that they're effective for things such as depression. So if your child, went from kind of their typical normal self, happy-go-lucky, friends doing well in school, to to over a period of time, no longer really engage as much, not wanting to do the activities they typically do, feeling more sad, more tearful. Their sleep and appetite might be affected. They might have trouble with their focus. They might be suffering from a depressive episode, in which case an antidepressant such as an SSRI would be effective. We also can see that antidepressants aren't just good for depression. They're also good for conditions such as anxiety disorders, for OCD or obsessive-compulsive disorder, for bulimia nervosa, one of our eating disorders, as well as for post-traumatic stress disorder. So when people develop acute symptoms after experiencing a traumatic event. And when we think about the various SSRIs, you might have heard things like Prozac, Zoloft, Lexapro. They all typically have roughly similar efficacy levels when it comes to treating various child and adolescent psychiatric disorders, and they all have similar side effect profiles. They do differ in slightly kind of, this one might be a little bit more sedating, or this one might be a little bit more activating, or this one might be a little bit more associated with weight gain, while this one isn't. So there are slight variations, but overall they're very similar with regards to efficacy levels, and then they all have the same risks of side effects. It's just kind of the percentage of individuals that will be affected by each medication has a slightly different kind of percentage of people that will experience each side effect. So if your child were recommended to start on an antidepressant or an SSRI, how do we dose this? So these are medications that kids will take once a day. It's not an as needed medication. So I think a lot of people oftentimes think about, okay, if I take this pill, all of a sudden I'm going to feel happy, or I'm going to feel less anxious, or I only need to take this medication on days where I'm feeling anxious. That's not the case. This is a medication that you need to take consistently that needs to build up in your system. It's not like a Tylenol where you take it and all of a sudden your headache is gone. For depressive and anxiety disorders, as well as for OCD, more treatment benefits are at higher doses, although with higher doses, you also can see more side effects. And what you want to be mindful of is that dosing really should be individually tailored to each patient. So you'd be working with your psychiatrist to see both kind of what the benefits of this medication are. Are we reducing the anxiety levels? Are we reducing the OCD symptoms, as well as kind of tolerability? So is this patient experiencing side effects? Are they, you know, having really upset stomach or a lot of headaches? You might have heard or seen on commercials that when we start an SSRI, we wait 4 to 6 weeks. And why do doctors say that? So it's interesting, kind of the science behind it, which is that we know that after a single dose of an SSRI, the levels of serotonin, so that chemical within the synapses, so within the two neurons talking to one another, is going to increase. However, we know that the clinical improvement in symptoms actually can take several weeks. So it's not up until about 4 to 6 weeks that we expect to see the full benefit of the medication. And the proposed mechanism, for those of you interested in science, is that once there's increased serotonin or that chemical within the space between the two neurons, that the receptors, the serotonin receptors, get kind of sensitized to it because they're seeing so much more. So they actually decrease the amount that are there. And that it's actually that down regulation of those serotonin receptors that leads to the benefit in depression, anxiety, and other disorders. And, this is, the proposed mechanism and what we think might really be helping the overall kind of mechanism that's leading to the improvement in symptoms. When a child or adolescent starts an antidepressant, you things they might experience are they might experience gastrointestinal side effects. So they might experience nausea, diarrhea. They might feel very kind of stimulated or activated, kind of jittery, trouble falling asleep, this restlessness. Alternatively, some kids might feel more sedated or tired on the medication. And then we also can see headaches as well. And typically, with these types of side effects, they tend to go away with time. So as long as they're not too severe, oftentimes within a couple of days to a week or so, these side effects will go away. If they're very significant or impactful, you could always stop the medication or start at a lower dose. So persistent side effects, ones that we wouldn't expect to go away with time, tremors. We can see patients will report vivid dreams, so kind of unusual, strange, very detailed, lifelike dreams. We also see weight gain. So we know that usually short-term treatment of about 2 to 3 months usually causes little to no weight gain. And studies looking at weight gain associated with SSRIs from 6 months to 3 years, the weight gain ranged from about 1 to 3.5% increase in baseline body weight. So if your child weighed about 100 pounds, that would be a 1 to 3 pound weight gain. And we know that the underlying mechanism for this is that we know that some people who experience depression, one of their symptoms is a decreased appetite. So if we're actually treating the appetite, and they might actually have lost weight during the depression. So if we treat the depression, they might actually gain back the weight. They might have an increased appetite from the medication itself, as well as you might have heard of things like carbohydrate craving. So kids really kind of craving sweets and cookies and crackers and those types of foods. And the final persistent side effect is sexual dysfunction. So roughly about 30 to 50% of individuals on SSRIs will experience sexual side effects. This can include decreased sex drive, decreased achieving and maintaining erections, and difficulty achieving orgasms. If this does occur and it's bothersome, you can try a reduced dose, you can switch a medication, or you can add a medication to treat the sexual side effects. Depending on the age of your child or adolescent, this might not be as big of a concern. And we do know that typically these side effects are reversible upon discontinuation of the medication. So what happens if my child misses a dose? Well, they might experience what we call a discontinuation syndrome. So in severe cases, they might have like a flu-like sickness, dizziness, headache. They might kind of feel pins and needles in their body. Brain zaps is a common thing where they kind of feel like these electrical currents, nausea, diarrhea, as well as they might have trouble falling asleep. Nothing about these discontinuation syndromes can be very bothersome and uncomfortable. They don't necessarily happen with every single antidepressant, and they don't happen for every single patient. A lot of people will miss a dose, and they might not even realize that they had forgotten a dose. Discontinuation syndromes, although bothersome, are not life-threatening. They're not damaging to your body by any means. They're just kind of basically uncomfortable. A common thing you might hear from your child, or that you yourself have a concern about, is that your child feeling numb on an antidepressant, that it kind of, takes away their personality and they feel really kind of flat and not like themselves. So there is a thing called apathy syndrome, which typically occurs after months or years of successful treatment. It's characterized by low motivation, feelings of flatness, and tiredness. Typically, what you would do is stop the medication and switch to a different antidepressant if indicated. It's believed that this syndrome is kind of dose dependent. So the higher the dose, the more likely you are to experience it, as well as reversible. However, when a patient reports they're feeling numb, we don't want to instantly assume it's because of the medication. We want to be thinking whether or not this is because the patient's maybe depressed again, or they're having other psychiatric symptoms that could look like an apathy syndrome. Another common thing that all parents should know about before starting their child on an antidepressant is about the black box warning about suicidal ideation. And so you might hear someone say, I heard that my child is more likely to become suicidal if they start an antidepressant. So where does this concern come from? So there is a black box warning, which sounds very scary, on antidepressants that states that there's an increased risk of suicidal thoughts for children and adolescents and young adults less than 25 years old. So these are suicidal thoughts, not behaviors, not suicide attempts or completed suicides. And this was based off of what's called a meta-analysis, or when they look at all the data from multiple studies that looked at the rates of suicidal thoughts in children with depression, anxiety, OCD, some other disorders as well, and compared those who were receiving antidepressants versus those who were not. So the meta-analysis found that 4% of patients in the sample who took antidepressants had suicidal thoughts, while only 2% in the placebo group, so the group that was not getting medication, had suicidal thoughts. And so the big headline of this was that antidepressants double the risk of suicidal ideation in children and adolescents, which is obviously very concerning. And in response to this, we saw a steep decline in the rates of prescriptions for these populations. There have been some, criticisms of this warning, which is kind of considering, 4 versus 2, the relative risk is, 2 times more likely. However, the absolute risk is pretty low. And at baseline, we know the prevalence of suicidal thoughts in teenagers is estimated to be 15%. That's even without any psychiatric disorders, with depression being a risk factor for suicidal ideation. We know that suicidal ideation or suicidal thoughts is so associated with depression that it's actually one of the symptoms of major depression. And what was relieving about these studies were there were actually no completed suicides in the studies. It was just, they were just looking at suicidal thoughts. And so look, what I like to tell my parents when they're thinking about starting their child on an antidepressant is that there might be a small cohort of patients that do truly experience an increased risk of suicidal thoughts when they start an antidepressant. And that's why why we monitor it so closely. Whether it's them checking in with their therapist, or I myself might actually check in with them a week after just to make sure that they're not experiencing any significant side effects. But overall, kind of the benefits of treating things like depression, anxiety, OCD outweigh that kind of small risk. But reasonably so, parents are very much concerned about this. And so I always want to make sure that I'm working closely with a family that feels comfortable with this information, knowledgeable about this information, and feels like there's a plan such that if this side effect were to occur, that their child would be able to be kept safe. So when do we consult a psychiatrist? Um, so to your left of the slide are 5 different conditions that we know there are either indications or evidence for the use of antidepressants, specifically selective serotonin reuptake inhibitors, um, for benefiting these 5 different disorders. We also know that there's a lot of evidence-based psychotherapy as well. And so we're always, when we're thinking about kind of treatment options, we're always thinking about therapy options, we're thinking about medication options, and then we're thinking about combined treatment where the patient's getting both medication and therapy at the same time. And this is really kind of a discussion that you would have with your patients or with your providers about kind of the risks and benefits of the treatment options for your specific child. With medication, oftentimes we will look towards psychotherapy as a first line treatment because medications obviously have more side effects compared to the psychotherapy. But we will start medication if there are severe symptoms, if psychotherapy is not available, or if a patient's already started individual psychotherapy and has not been able to make progress. So a classic example I like to think about is, the kid that's so anxious that they can't even sit through and engage in their psychotherapy. And maybe they need, an antidepressant to start in order to help kind of decrease their levels of anxiety such that they can get some benefit from the therapy. So that concludes my presentation. Are there any questions? So the first question is therapy recommended alongside medication? And the answer is absolutely yes. There are really great evidence-based psychotherapies for these disorders as well. And so we always want to be thinking about including psychotherapy within our treatment. If we look at kind of the studies that look at things like anxiety, depression, OCD, typically what we find is that combined treatment of using medication and psychotherapy is the most effective option. That's not to say that that's what we're going to start with each patient, because the more treatment you get, kind of the more potential side effects the patient might experience as well. So how do we talk to teachers or other caregivers about this? Are we obligated to tell them? Uh, so the answer is no. Um, typically if you're when I'm starting a patient on an antidepressant, oftentimes I'll have them take their first dose on the weekend. That way, if they have things like stomach ache, headaches, a little bit of nausea, they're they're at home and so they can be more comfortable than in school. But there's not really necessarily a reason that you need to tell your teachers about this. If you had specific kind of safety concerns about your child's mental health and they're spending a lot of time in school, that would be a reason to talk to your teachers. And you can share this information. There's nothing wrong with it, but I don't necessarily think you are obligated to. Um, and then an additional question is, how will I know if the medication is working or if it's making things worse? So typically once you start a medication, you're going to be meeting with your psychiatrist, whether that's probably in the beginning about maybe once a month, to kind of review your symptoms, the reasons why you started the medication, and to track whether or not those symptoms are getting better or worse. So that's kind of you would kind of continue the relationship with your psychiatrist in order to track its progress. And so what happens if we want to stop the medication later on? So that's also a conversation that you would have with your psychiatrist. Starting a medication, an antidepressant, does not mean that your child will be on it for the rest of their life. And so if the medication's not working, if the medication is causing side effects, or if a patient has, experienced kind of remission or improvement in their psychiatric diagnoses, they've been doing really well for a long period of time, whether that's, maybe about a year or so. And at that point, you want to kind of think about stopping the medication. When you stop a medication like an antidepressant, you typically wean a patient off of it. So you're going to slowly be decreasing the dose over a period of time, probably like weeks to months, depending on the individual, and monitoring, for any reoccurrence of symptoms. So it looks like we have no more questions for today. On behalf of the Department of Child and Adolescent Psychiatry, thank you for joining us today. You can find a full list of our upcoming webinars, as well as recordings of previous webinars at nyulangone.org/csc webinars. Thanks again. Bye.